Afternoon, everyone, and thank you for joining us. My name is Debbie Keatley. I'm a Use My Data member, and I have been for a long time. I am a cancer patient, and I think we're probably one of the loudest voices in the room demanding that data is used. So with me here today is Chris Carrigan, who's the expert data advisor to Use My Data, and he's part of the secretariat which supports Use My Data. Apparently, according to Chris, I'm chairing and he's here to support, but I think we're co-chairing. And we'll be keeping an eye on as many of the questions as we can throughout. There's a lot of people joining us today, and we'll make sure that everything is answered. If not today, we will come back to it. Some of you may be new to Use My Data and to our webinars. Do have a look at our website. It's usemydata.org. I think first and foremost, we're people. We are a UK movement of patients, of carers, relatives. We're the only independent patient movement that's focused on patient data, as far as I know. Things change by the day. We focus on highlighting the benefits that using healthcare data can make to save lives and to improve care for everybody. And I think it's worth saying about our vision statement, we would like to see every patient willingly giving their data to help others, knowing that there are effective safeguards in place to maintain the confidentiality and anonymity of their data, and that they're applied consistently, transparently, and rigorously. We engage positively with a wide range of stakeholders around the ways that patient data can be managed and used, including through webinars like this. And I want to say up front, we rely on, I think, what is called a cocktail of funding for Use My Data to work. For transparency, I want to highlight today that in August this year, we received some funding from NHS Digital and NHS England to support the Secretariat. And I also want to make it crystal clear that this funding is provided on the basis that neither NHS Digital nor NHS England have any say or influence in the work of Use My Data. Everything Use My Data does is defined entirely by its members and through the advisory group. So for the webinar today, you will see that your microphones and cameras are disabled, but you should be able to see and hear our panelists on screen. Please use the Q&A throughout the session. As questions arise, pop them in the Q&A box so you don't forget them. We're expecting there's going to be quite a few questions today. You should be able to see other questions too. If you keep an eye on the Q&A box and see a question that someone else has asked that you think is important, please vote it up. I'll be putting the questions to the panelists during the session according to the votes that it receives, and we will get through as many as we can today. Again, we will come back to those that we don't manage to get through. We're recording the webinar today, and we'll have this on the Use My Data website, along with highlights of the key points and the actions that we do need to follow up. And feel free to use your social media throughout. If you'd like to tweet, please tag us, use my data, and you can use the hashtag #DataSavesLives. As is usual with our webinars, we've got a very mixed audience today of patients, carers, relatives, NHS, academia, commercial companies, and more. So at the last count, I think there was about 250 delegates registered, which is a personal best, I think. Today's topic was, like all Use My Data events topic, it was defined and agreed by the members of Use My Data, by those patient relatives and carers. And what we want to talk about today is we're looking at the question of whether NHS data is sold. We know that if you ask that, what seems to be a fairly straightforward question, is data being sold, you'll get a yes or a no depending on who you talk to. But we want to uncover that a little bit and look at the complexity underneath it. We also want to look at the reality as understood by experts in the field. And we want to ask your questions of our panel of speakers to explore how the NHS can make its data available. What are the costs of that? Who pays for this? And ultimately, what's the public value? What's the public return? And how can we all assure ourselves that what we hear, the good news, is that what is happening? Do we hear everything? So we've got 8 speakers with us today from across the UK, who will each describe their perspective of how data is used to try and bring some clarity to the areas of costs, selling, buying, who benefits. And we've asked all our panelists to avoid acronyms as far as possible, and we will hopefully be able to stop and make sure that if somebody mistakenly says an acronym, that we can try and explain it. Please speak in plain English and try to keep this focus on patient audience. If there's something you don't understand, please use the Q&A function. So this is a longer day because it's a big session. It's 3 hours. We will be having a 15-minute break part of the way through because I don't think any of us will be able to cope with 3 hours in one go. So to get us started, we just want to test the tech, and we're going to have a poll. And question is, do you think the NHS sells patient data? And if you could just answer that. And how's that going? What have you got?
It splits. It's almost even. Yes, no, and I don't know.
Okay.
Which says to me, there's a good need for this because there seems to be a huge amount of uncertainty about whether data is sold or not and what it means.
Yeah.
So we'll rerun that one at the end of the session to see whether this has helped anybody. And let's hope.
Okay, so for the first part of the webinar, we've got our first 4 speakers. We have a joint presentation from NHS Digital and NHS England, and that's Michael Chapman, Claire Bloomfield, and Kelly Lynn. And then we have a second presentation from Phil Booth from MedConfidential. So we have Joe Gumbs here, who's a member of Use My Data Advisory Group. And after each of the presenters has spoken, we're going to ask for one response or question from, I suppose, a patient or public perspective, and that's from Joe. And after all the speakers have spoken, we're going to open up more widely from questions from you. So again, please use the Q&A function in Zoom and let us know if you're having any difficulty with that. And first up, I'm going to start the webinar. I'm going to ask Michael, Kelly and Claire to speak about the roles of NHS Digital and NHS England and the way that data in England is collected and managed and secured and used. Okay, great. So I think that's Michael first, is that right?
It is me. Thank you very much, Debbie. I'm going to share my screen. Hopefully this will work. It worked in the practice, but who knows? So hopefully you can now see a set of slides. Great. So hello, everybody. My name is Michael Chapman. I am the Director of Research and Clinical Trials at NHS Digital, and I'm the first of 3 quickfire speakers from NHS Digital and NHS England this afternoon. My part in this is to tell you about the approach we take at the moment to this topic at NHS Digital. I'm sure lots of this audience will be familiar with NHS Digital, but in case anybody isn't, we are the central data and technology body for the health and care system in England. And as such, we collect a wide range of data sets that are used to plan and manage that system. We publish open data and statistical publications, but we also make that data available to external users. And I'm responsible for the services that do that. Again, this audience will be aware the data we hold has immense potential to improve health and care. And many of the most impactful research studies using data from the NHS are supported by NHS Digital. I'm not going to go through those in detail. That's another much longer session, but I've included here a traditional wall of logos for some of the recent work where we have provided data. And to put this in context, at any one time, NHS Digital has about 1,000 data sharing agreements, split roughly evenly between research and NHS planning uses. Debbie mentioned transparency earlier. You can see those on our release register. There's a link to that on one of my next slides. And throughout this data sharing process, we are very, very aware of the privilege and the responsibility that comes with holding this data, which ultimately comes from all of our interactions with the health and care service, and with ensuring that that's used for the right purposes to benefit health and social care. So requests to use the data that we hold go through a process for application and review. Our staff support users to apply and then to review the applications with oversight from an independent panel. And when applications are approved, we prepare data sets to the approved specification. That often involves linking data, deriving new cohorts, and minimizing the data set being provided to the use envisaged. We audit a subset of agreements. Teams either go out, or at the moment they often conduct the audits virtually, but they go and check that people are doing what they say they're doing, that the conditions imposed in our data sharing agreements are being complied with. And where those conditions aren't being met, we publish the audit reports. And we then follow up to require data deletion at the end of projects. You can see down at the bottom a couple of screenshots of our data uses register. You can go and you can see all of those 1,000 current data sharing agreements. You can see the historic data sharing agreements, and elsewhere on our website you can read those audit reports. So that's a hugely important process, but doing it incurs costs. We're doing this at large scale. We have to employ staff to manage the system. We need to reimburse our independent advisors. They spend at least a day a week in a meeting reviewing applications, and often they're advising us on other issues in between. And our teams are dealing with roughly 350 new data sharing agreements each year. So this is a large scale operation. Which brings me to the point of this session, which is that we operate on a cost recovery basis. We aim to recover the costs of supplying access to data from the users of those data. Because if the users of the data don't fund that activity, then the NHS would need to pay for it, either by reducing other activity that NHS Digital conducts, or by taking money from frontline services. So we operate on a cost recovery basis. We don't charge for the data itself. We're collecting that anyway, so there isn't a marginal cost of data collection. But we do charge for the cost of reviewing the application, of preparing the data to the specification, and of ensuring compliance. Our charges are public. They're on the right-hand side of this slide. They're also on our website. And then on the left, which is also public, but maybe less visible to people, I've included an extract from the accounts that we provide to Parliament, showing the income and expenditure in this area. So in 2021, you'll see that we had income of about £3.5 million and expenditure of about £6.8 million. There's a quote from Dickens about the results of your outgoings exceeding your income, which I'll get wrong if I try to remember it now, but I'm sure you know the one I mean. So to reassure on that, the deficit is largely down to us not charging a fee to NHS bodies or to local authorities for their healthcare functions. That work's covered by our grant and aid from the Department of Health and Social Care. So you don't need to pass the hat around for me just yet, but I think it's important that's visible and understood. So I'm hoping that that gives you a bit of an understanding, a really quick summary of the approach that we take at the moment, and why it's important that we recover the costs of providing access to the data held by NHS Digital. The fact that we are not making enormous amounts of money for the NHS out of this. We are recouping the costs that we incur to ensure we're not detracting from other NHS services, and that this is an issue that we do think long and hard about. So I'm going to hand over now to Claire, who's going to widen the picture a bit to the rest of the NHS. So Claire, over to you.
Thank you, Michael. So Michael's kindly going to be doing my next slide for me. So thank you, Michael, for picking up that extra job. I won't charge you for that either, as a service relationship between the two of us. So as Michael said, I wanted to give you a slightly broader perspective beyond NHS Digital. NHS Digital is obviously a key part in terms of the way that data is shared across the NHS, but not the only part. As I wanted to give you a little bit of context around some of the broader data sharing and data access that happens for research and innovation across the NHS, both from a policy perspective, but also some of the work that's been underway and is emerging to make this system work more efficiently and effectively. So next slide, please, Michael. So 2.5, I want to say, just before the pandemic, the Centre for Improving Data Collaboration was established. And this was positioned within what was then NHS X, and apologies for the acronym, there isn't a long version, it is just X, to foster more widespread data-driven innovation and better partnerships between researchers, innovators around harnessing the value of data in the NHS to drive more impact for patients. And I want to stress particularly the word value there. and the way that we think about different types of value that are generated through the use of data for research and innovation. And my colleague Kelly will talk later about the financial or commercial benefits or value from that data, but wanted to note now that we consider there are a range of other types of value that the centre is also considering. Fundamentally, the core and heart of this is patient benefit. So how do we use data to generate new medicines, new insights that can be used for improving patient care? How can we think about learning and knowledge transfer between research and NHS care delivery, and how do we embed that into the NHS as a whole, as well as training and improving the workforce's experience, and a range of other components around what we consider value exchange. And the centre was set up in part because there was an appreciation that there was a great variety in ways in which NHS organisations at an individual level, locally, so GP practices, NHS hospitals, were forming partnerships and collaborations with industry. And they varied significantly in terms of how they were defining or categorising what the value was of the data that was being used as part of those innovation collaborations. And so the centre was designed to help foster more standard approaches to that, to help provide guidance to individual hospitals, as well as at a national level, including with Michael and NHS Digital, about what does fair value look like. And we've not just been talking about that from a policy perspective, but also embedding that into some of the investments we're making to improve the way the system is working. And that's particularly where my work takes place, which is in terms of accelerating the amount and types of data-driven research and development that is underway. Next slide, please, Michael. So the programme, the Data for R&D programme, or Research and Development, was set up in March of 2022 in its current format, with an investment from the government of up to £200 million to really change the way we approach investing in the necessary infrastructure, both in terms of people as well as technology, to standardise the way we're approaching access to and uses of data for research. And that programme is reflective of two key documents that were produced this year. One is the Goldacre Review, which focused on better, broader and safer uses of health data for research, and which made a number of recommendations around how we should move to data access rather than data sharing. So rather than handing copies of the data out to research and innovators, how we bring the researchers to the data and keep that securely within the NHS environments. And that's been reflected in the Data Saves Lives strategy, which commits us to a range of investments, including those through the programme, to ensure that we are creating the right solutions to bring people to that data securely and transparently, and that those environments then provide the frameworks in which we can have the conversations with individual innovators about what's fair value. If you want to access this data, what are the appropriate commercial and contractual terms associated with those? So I've given you a sense of the landscape in which the conversations around commercial principles happen. And these all have the goal, Michael, next slide, please, to really ensure that by the end of 2025, we've got an NHS-wide infrastructure for research and innovation that can enhance patient care, so that core value of how we're using data for patients. It can help sustain the NHS, as well as supporting innovation so that we get the right treatments to the right patients in the next 10, 20 and 50 years' time using the data that's generated right now. So I'm going to stop there and hand to Kelly, who's really going to drill in and focus on if we've created the right environments to talk to innovators about uses of their health data in the NHS, what should the terms and the value commercially and contractually look like for some of those partnerships? Over to you, Kelly.
Thank you, Claire, and thanks, Michael. Can you move on to the next slide, please? Thank you. So I am Kelly Lynn. I work in the same team that Claire talked about, the Centre for Improving Data Collaboration within NHSX and now NHS England. As Claire said, the part that I'm responsible for is setting the set of principles by which we govern this value sharing partnership between the NHS and industry, researchers and other innovators coming up with new ideas to support patient care. Back in 2019, before our team was set up, the Department of Health published 5 principles around data partnerships, and I just wanted to take them each in turn very quickly. The first and most important one, I think, as Claire and Michael have mentioned, as Debbie mentioned at the beginning, is we need to make sure that every single opportunity which NHS data is used has an explicit aim to improve patient care and welfare, and that has to be the guiding principle that governs every single time data is being used. The second part, and the bit that I'll talk about in a bit more detail, is that partnerships should deliver fair terms for the trust and for the NHS as a whole. Thirdly, we cannot prevent the use of NHS data for other beneficial purposes. This essentially means no exclusivity, and I think it's a really important point, especially when we talk about, are we selling NHS data? The idea is that actually we have NHS data, and it can be used, the same data can be used again and again to drive innovation that improves patient care. What we cannot have is situations where the data is only used once or leaves NHS environments and no longer brings back value to the NHS. Fourth, any single use of NHS data has to be clearly and transparently communicated to patients and the public, and Michael showed earlier how NHS Digital does this and publishes how its data is shared and in what way. It's important that that is shared across the NHS for all uses of data. And finally, users have to adhere to all applicable laws and regulations, including GDPR. I think this is incredibly important, and policy is developing in this area that suggests that whenever possible, data should remain within secure environments within the NHS rather than leaving the NHS. So I'm going to talk about the first two of these in a bit more detail. Michael, can you move on to the next slide, please? So as Claire mentioned, there are lots of different ways in which we can think about value sharing. The most important thing is this data that the NHS holds can lead to substantial improvements in the way that patient care is delivered in this country. It can lead to hospitals being more efficient in the way they deliver services and able to see more patients at one time. I think really importantly to me, many of these technologies are developed internationally. It's incredibly important that they are tested and configured to UK environments so they suit populations in our country. And that requires the use of NHS data. Finally, there's an important aspect around knowledge exchange. We have incredibly innovating and smart people in industry, in universities, and it's really important when they work with the NHS to develop new ways of doing things that can really help drive improvements in patient care and welfare. Back in the last 5 years or so, there's been some work done with patient groups and the public, looking at public views around access to this data as well. Understanding Patient Data in 2020 did some work that suggested that 81% of people believe benefits that come from health data partnerships should be distributed across the NHS. And Ipsos Mori, in supporting a patient deliberation done around London, found that over 60% of people would rather that commercial research organisations have access to health data than society miss out on the benefits these companies could potentially create. Can you move on to the next slide, please, Michael? But I think as Claire and Michael alluded to, NHS Digital isn't the only organisation that has access to NHS data. NHS data is spread across NHS hospitals, GP practices, and many different locations. And the challenge we have is that there are often inconsistent, long processes around access to this data that aren't supportive of driving innovation and important research. And secondly, while some NHS organisations are very savvy in terms of getting the value back, that expertise isn't really shared across the NHS. And so the role of my team really is to set more standard principles around access to NHS data, around a commercial approach, so that we can standardise some of what is happening. So what we are doing is developing a simple and consistent approach, and we've got 3 aims in this order. The most important one is whatever approach we have around access to NHS data needs to be aimed at maximising patient benefit, improving the way the NHS operates, and improving staff motivation and retention. But we also recognise that in supporting all this innovation for patient benefit, there is an opportunity to deliver benefit to taxpayers through supporting industry, and there is also an opportunity to bring back income to the NHS. So we're walking, I suppose, a fine line in making sure that we can support innovation whilst also bring back value to the NHS at the same time. And can we move on to the next slide, please, Michael? And so this chart essentially shows the range of options we can take when it comes to value sharing the value of NHS data with industry and researchers. On one end of the spectrum, we can provide access to data for free. And I think Michael has covered why this might not be preferable. It costs money for us to be able to collect this data, curate it, and put it in secure data environments and to process access requirements. If we don't charge for access, then essentially what we're doing is taking money away from the front line of the NHS. In these resource constrained times, I think many of us would agree that's probably a bad idea. So it's incredibly important that we at least cover costs of access, particularly by commercial companies and industry. We are now moving to an approach where we want to share in the financial benefits of this research as well. A lot of the time, I think it's fair to say, although there are really good intentions, the research may not lead to commercial outcomes. In that respect, that's fine. It's really important that we cover our costs. But in other cases, we can support industry, we can support this data can be used to develop new techniques of treating patients, new ways of improving the way that hospitals work. And a lot of that can be sold abroad and can generate a lot of value for industry. And it's important in that respect that we share in some of those benefits for the NHS, and we recognise that this data came from the NHS and that can be ploughed back to support the front line. We can also maximise income for every single data use, and we're not proposing to go down this route. One of the reasons is because this is an incredibly complicated commercial negotiation. And what we really want to be doing, as I said in the previous slide, is in supporting innovation and supporting industry. So we want to be supporting the generation of new ideas that improve patient care. And if we prevented access from a lot of researchers who can do good things, then we are essentially shooting ourselves in the foot for the longer run. So our commercial approach at the moment looks at covering costs, but also, where possible, sharing in some of the financial benefits of innovations that really improve patient care. That's it for me for now. I pass it back on to Chris.
Thank you all. I think Joe, is Joe there?
Yes.
Is there anything immediately that strikes you that you want to come back on with a quick question before we go to the next slides from Phil?
Just wanted to say, thank you for that, because I think that was a really nice sort of summary how it helps patients. But you said that you operate cost recovery, but can I ask why you don't sort of go a step further and actually generate a surplus of funds by charging more to the commercial users, so that money can come back into the NHS?
So I'll answer first, and then I think Kelly would like to come in on that, I'm sure. But the current model is fairly long-standing and based on balancing some competition law and the guidance from Treasury around managing public money, and indeed reuse of public sector information, which states that essentially public bodies should be making information available at marginal cost, but they shouldn't be undercutting other organisations that might have that information. So recovering our costs but not making a surplus is the way in which we work at the moment. Kelly, however, she was just saying, is thinking about how might that model change in the future. So Kelly.
Yeah, absolutely, Joe and Michael. So we want that model to change in the future. We absolutely want to recover our costs, but we want to go further beyond that where possible, without damaging the amount of innovation that takes place in this country. And I think that's incredibly important, because what we found is that lots of companies are willing to pay more for access to NHS data, where that, whilst obviously being clear that that data is for patient benefit and kept in secure environments, but companies are willing to pay more. And I think that's really important. We do take a share in some of that surplus, because we also at the same time have lots of hospitals that are still using paper-based systems. That money needs to be ploughed back into the NHS to support improving our digital capability and our delivery of services. So absolutely, that's the direction we are going down.
Thank you.
Thank you. Is that okay, Joe? In which case, just a quick reminder to the rest of the delegates that there is Q&A questions going in. If you see a Q&A question you like, please do upvote it, or indeed put your own question in as well, because we'll be asking these after the next session, which is, shall I just let Phil introduce himself, Debbie? I think so.
Yes, you do that.
Hey everyone, I'm Phil Booth. I coordinate MedConfidential, and we seek to ensure that every use of patients' data is consensual, safe, and transparent. I will now attempt to share my screen. I'm doing this all myself, so forgive me if it takes a moment. So a couple of things just before I launch in. The title of the thing is, does the NHS sell my data? We've talked about, or previous presenters and colleagues have talked about NHS data. Okay, there is NHS data. It generates operational data. It generates a whole bunch of stuff. What I am talking about, and the people that I advocate for and represent, i.e. patients, is patients' data, NHS patients' data, the stuff that's in your medical record, the stuff that is generated by virtue of you being treated by and receiving care from the NHS, for which we all pay through our taxes. So let's be very clear, I'm talking about patients' data here. It seems that we've got some similar ideas about things that we should put on our slides. I basically think the answer is yes, and I know that many people agree with me. The NHS does sell data. It doesn't matter, yeah, if you say no and then go on to justify what you're doing. Yeah, if you say no and people can see a table of charges and there are charges on there that clearly aren't just cost recovery, you know, simply a license to do something else with the data isn't, you know, costing you anything more. You know, the reasonable person's understanding of selling stuff when something changes hands under some sort of commercial agreement and money changes hands as well, you know, means that I think it's reasonable that people do believe that the NHS sells data. MedConfidential doesn't actually have a huge problem with that. Yeah, we just know that many people do, and for various reasons. Yeah. Michael showed the sort of improved sort of web front end of this. This is the data uses register that NHS Digital puts out. I must say, really quickly these days, you know, over the years, this sort of cycle of being transparent, showing what you're doing with data and everything else has massively improved, and NHS Digital is at the forefront of that amongst the Department of Health NHS family. So kudos to them for that. But as you'll see in this spreadsheet, I've highlighted some lines. All of these that have any highlighting at all on them are things that can be used for commercial purposes. And there's also some in there that have this sub-licensing or reuse arrangements as well. Yeah, so, you know, let's be clear. We talked about all the positive things and logos of all the great stuff, but, you know, I'm going to focus on what is actually going on. And this is September's data usage register, I think going up to, you know, just the last few weeks of August. And this is what's going on. Yeah. I picked the one that I highlighted in yellow. Yeah, that bright yellow one, Harvey Walsh. I picked it because, you know, they came into focus in 2014. Most people remember that for the care.data program, but it was actually the HES scandal which prompted the Partridge Review and the changing of the name from Health and Social Care Information Centre to NHS Digital ultimately. Back then, they were broadcasting, you know, trumpeting. We've got 1 billion linked patient HES records. Yeah. As of today, this same company, trading under another name, like NHS Digital does these days, has moved from a billion claim to an implication of infinity. But look at the yellow text down at the bottom. This is to prove the continuity. You know, this open health organisation, yeah, which services a whole bunch of different clients and industries, not just NHS or local authority or universities. Yeah, as we'll see in the middle of this slide, 3 or 4 paragraphs down, the life sciences industry, pharmaceutical companies, medical device companies. Yeah, we are talking about straightforward commercial companies here, and this is what we know people care about. Okay, But now I'm not proposing to go through this whole long, boring sort of sets of terms and conditions, just pick out a few highlights. Let's be very clear. Harvey Walsh, and I think the register says this as well, says it's a sole data controller. You can only be a data controller of personal data. If the data is anonymous, it's not personal data. Therefore, you can't, data protection law doesn't apply. You're not a data controller. So just in the very first line, we are clear, everyone is clear, we are talking about personal data here. Something's been done to it, but it's still personal data. If we go further down this slide, where it starts to go into single line statements, and I've highlighted that the data we receive is pseudonymized and non-identifiable. This means individuals cannot be identified from the data. Well, how are you linking reliably patients' data over time then? Yeah, it may be true that the data is not identified, but pseudonymized data is identifiable data, and it is identifiable because each patient can be individuated within the data so that their records, hospital events and what have you, can be linked over time. Otherwise the data is useless. You can't be sure that you're linking the right data about the same person throughout. Then clearly you couldn't be using it to drive all sorts of interesting stuff. And the final point I make, the bottom bit where it says opt out from PES, well, Harvey Walsh rightly say they don't hold the direct identifiers to be able to remove your data from what they've got. But that is only because they get data from which people's opt-outs have not been respected. So this is what we presented to drive some of this debate along. You'll see our little cookie banner at the top. You can all go and visit this. But Harvey Walsh, if you look right down at the bottom of the screen again, it's in there. Now, it doesn't opt out. It doesn't honor opt-outs. It's getting pseudonymized data that opt-outs are not respected for, and it's had in its audits, it's had an unreported data breach and breached its contracts. And yes, it's still receiving data. This is, we can talk about all the fine stuff, but once you actually get into the detail of what's actually happening, things need to improve. And as my NHS colleague said, and we're choosing some of the same slides again, things will improve. We certainly hope they will. Obviously, the Goldacre Review pointed to what we could call a trusted research environment, TRE world. Turns out the NHS wants to call them something different, but the basic principle is the same, that the data is held in a single place and people who are approved come to it with projects that are approved and can only take away insights, not data, sort of results, tabulated results, if you like, but not actual data, as happens at the moment, where they are handed vast quantities of generally pseudonymized data. This is a sensible approach. It's what we've been advocating for since 2013 when we started, and ministers have now promised that this is, certainly in regard of GP data, patients' GP data, it won't be extracted for planning or research uses until a trusted research environment is properly up and running for planning and research uses. I push back a little bit on some of the data saves lives claims. We began, MedConfidential began doing work and being asked, invited to engage in work around what is the value of data years before the pandemic. As with Department of Health, with BIS, the business department, and OLS, the Office for Life Sciences. That was years before the pandemic. And if you read the section in Data Saves Lives, there's only a commitment to come up with the value framework for commercial use by the end of December next year. What is taking such an extraordinary amount of time, to actually come up with what you would think or would hope would be something we would have sorted out some while ago. Anyway, that's about selling data. I want to raise other commercial activity. Yeah? There is marketing to patients via NHS endorsed apps that have commercial business models. Some of the suppliers to the NHS, for example, EMIS, one of the main GP IT suppliers, has a marketplace attached to its offering to patients. We have instances of Minister Secretary of State even allowing Amazon's lawyers to write contracts for giving data which 1,000 other people have used an open data contract that suited them fine to get access to NHS UK content, but no, somehow Amazon was special, and Matt Hancock signed off on a contract written by Amazon's lawyers, which gave Amazon special privileges, and to the extent that we were pushing NHS patients towards using Alexa, a nice little stream of guinea pigs. And there are other sorts of things than just money here. Notoriously, Palantir was given a £1 contract at the beginning of the pandemic, but that £1 contract, simply because it was could say it was now working with the NHS, was quite likely worth $100 million to them when they floated. An IPO is an initial public offering. It's when you put your company into the sort of stock market. That they could claim they're working with the NHS instead of just intelligence services and military stuff and all dodgy customers. There is value in being able to say that you are working with the NHS. Just to pick up on one of them, I saw the one I mentioned at the top, Evergreen Life. Yeah, but you may well have seen this in other apps that you've seen. This is one of the GP access apps, one of the ones not like the NHS app, which we all now know, but the ones that have been doing that sort of thing. Some are offered by the GP IT suppliers, some just sort of are able to access. And this one will upsell you to chunky 70 quid DNA tests. Yeah, I thought we had a thing about not marketing to patients in this country. And that might be true around drugs, but around devices and apps at the moment, there is a whole bunch of activity going on, which really starts to equate, as I say, Evergreen Life's dodgy DNA tests, which at $69.99 is quite possibly they're doing it as a loss leader, not a cost recovery thing, associated as closely as they can with GP and actual NHS branded services. This, I contend, is an important thing in terms of how people trust what the NHS does around money and finance and value. And that's where I want to leave it. I know Kelly's working on it, and the Centre for Improving Data Collaborations is working on a task. But I think this is important enough, and we know that millions of people care about this because they express their choices based, at least in part, on what is done by commercial companies with their data. So I would like to talk, not keep on having this same old conversation. I think the answer is yes, as I said. I think that's every time that's been tested, we see that millions of people at least agree that people's data is being sold. So what do we mean in a TRE world by value? Yeah. And of course, the complexity, that wedge that Kelly showed on finance and money. It's all to do with public funds after all. Our taxes pay for this. And in some ways you could say we are paying also with our data in this data-driven world. And the final question that I have for Use My Data and everyone else, who gets to decide? When this has been put to the population, the last 2 times around GP data, the answers were not credible and they didn't satisfy people. So we actually need to be doing a far better job of working out that. Thank you. Thank you.
Thanks, Phil. I'm going to go over to Joe and see, Joe, do you have a question or comment after that?
Yeah, thank you, Phil. Yeah, I mean, I'm guessing, you know, you've sort of shown a whole new set of areas that we probably won't get to touch on today. But do you agree that this is really a question about having that clarity and transparency about how data is used, so that there's no surprises, and
Yes.
that there's absolute respect in what people want and how they want it used?
Yes, so I mean, we have the technology, as they say. You know, we are commissioning modern information systems at scale. You know, certainly the trusted research environments and everything. We are using pseudonymized data. A pseudonym is an identifier of a sort. People should be told how their data has been used. Yeah? It's as simple as that. Yeah? If people were to have like this equivalent of a mobile phone statement or a bank statement, they could see when or where their summary care record had been accessed. We've got the audit trail for that. We've had that for years. If they could see the research projects or whatever that their data had been included in, yeah, that would be something which could give people confidence that, okay, I know what's going on. Yeah, it would have other benefits, opening up a two-way conversation that we haven't previously had. But you know, transparency is not just publishing, you know, pages and pages and pages on a website or giant spreadsheets or this and that. The other, that's not how people interact with giant institutions. You interact around your data and what is done with it. Yeah, your phone use, your transactions with your credit cards or what have you. And it is that which I think would provide the channel for us to be able to talk about you know, the value that people see, and I honestly believe could actually help people to, over time, engage in like the research endeavour, certainly, you know, where we can see that it's okay, my data is not necessarily going to, you know, directly affect me, but it might affect someone in my family or, you know, my kids or grandkids in the future, or someone that I know, you know, but we don't get that from this abstraction of talking about stuff as if it is NHS data when it is people's data. And we don't and aren't actually really clear about exactly how it is being used. You start to try to justify it or divert people from, well, no, we've got to do this or we've got to do that, look at all the benefits. You know, that is a failed approach. It's failed several times at scale, and we need to do something different this time.
Brilliant, thank you.
Debbie, do you want me to pick up on some of the questions that have come in? So I was just going to...
Yeah, I'm just looking, as far as I can see, the top voted one is really about fair value. So it's going a bit further. And how do you audit that fair value has actually been achieved? And who does that auditing? And I think this is something that Phil's alluded to as well. So who would like to take that? Kelly?
Yeah, I can attempt to. So to be honest, Debbie, I think that's incredibly difficult. I think EY published a report a few years ago that said NHS data has the potential to bring about £10 billion of value. But really, the value depends on the user and the use. And Phil, you've asked the question here on why is it taking so long to get the value sharing framework out? But also, I think at the same time, you've raised a lot of the complexities with that we have to deal with around this question. So who gets to, it's a really difficult one, who gets to decide on the value, right? This person who decides is both the patient, the hold of the data, as Phil's completely right, it's their data, plus the user, plus how it's being used, plus, you know, factors relating to luck on whether something succeeds or not. So what we want to be doing with our future model is looking at cost recovery first and foremost, and then a small share of the value with a percentage back to the NHS for access to data. It probably won't be ideal, and I think I've said in my presentation, one of the big challenges we have is a lot of complexity. So you want to simplify as much as possible and get a relatively small value back from everything rather than optimal amounts from absolutely everything, which is incredibly difficult to achieve. So in answer to that, I think it's really difficult to decide what value is, but also in answer to Phil's final question, this is one of the reasons why it's taking longer, because there is no clear answer on value, plus that we need to do something differently to before, which means that we do need to share with patient groups, with the public. We've developed our principles as they are, and that we do which we want to publish in the value sharing framework. But we recognize that that needs to be discussed in a lot more detail with the patients and the public, of which this is the start, with the NHS organisations, commercial directors, clinicians, with researchers and with user groups, which we're all doing at the same time. So it's a conversation, I suppose, is the short answer.
I think, can I just add one bit, Debbie, because there's something that, so my background was as a researcher, so I've been the other side of this where you're interested in trying to do research, and what was a big shift in the funders of research was how do we measure the impact or consequences of research to get a sense of the public benefit that's been realised by investing. And 10 to 20 years of trying to do that well has proven it's really, really difficult. And it's really difficult to track the impact and outputs over the timelines of things you start to see. So unlike the vaccine and pandemic, normally the high quality impacts of big scale research take a long time to be measurable. So rather than focusing on what has happened, putting that marker in at what should happen at the data access request point, making sure it's compliant with those 5 principles, that we think it's in the public interest, that there is a valid reason for doing this, becomes key to doing that before you allow access to the data, as well as then reporting what is then done. But not, I think if you try to say that we track that value, you create a whole new industry in the public sector just tracking the impacts and outputs of data sharing, which I'm not sure would be a valuable addition to the system, and I think can be supported through good checks and balances around data access before we make those decisions. So I think it's just when we make those assessments matters as well.
So I don't entirely disagree on all points, but I actually, that's why I expanded from just value to finance and money, because that's stuff you actually can track, because companies have to publish accounts, and you can see their internal workings, and there are ways in which these things, in terms same way as data is audited, finances are audited. Having 20-30 years ago negotiated intellectual property at a university, you come up with an arrangement or a series of arrangements that says, if you meet your targets, that's fine, we get X. If you exceed it, we get a percentage more. If you don't, okay, well, we've got our cost recovery. These things are complex, but they are not total rocket science, and we should be trialing some of that stuff with the small subset of organizations that are actually quite evidently commercial companies with free use licenses. This is not 1,000 companies a year. This is a smaller subset of the overall usage register. However, I do think that if we talk about and keep on trying to sort of talk about value and tracking value out there, it gets away from the hard evidence base that we need. People make assertions about what they intend to do. People make projections in business all the time. If they meet or fail to meet or exceed those, then that is not an untractable problem. And if we are doing that with that proportion of users of data who are coming through the process, they're safe people, their projects are safe, the actual stuff that they're taking away, and this is the point, the stuff they're taking away shows that the value isn't in the data. The value is in the insights that they are generating. If we have a TRE world, they don't get to take the data away at all, but they get to take something away. That is where the value resides. So trying to put a number on the data is, just entirely wrong-headed in the first place.
Okay, I've got a couple of hands up from Michael and Kelly. So who wants to come back on that?
Well, I'm not sure I'm coming back on that. I fear that disappointingly we may all be furiously agreeing that the value is not in the data. We're not not out there trying to flog data. What we're interested in is generating insights, and those insights have the value. So I was going to, I'll let Kelly talk about how we might do that and why, I suspect again, I see her nodding, so she might be about to agree with you, Phil, about some of those IP provisions. But just in terms of the uses of those data and how we monitor those, I want to keep going back to the fact that all of these things have to have a benefit to health and social care. There are ways in which one could use NHS data and data from NHS patients. It's a very good point, Phil. Need to get better at that. But one could use those data that have nothing to do with benefiting the NHS and improving health and social care. And that's not okay. So we're not going there. But what we do need to do is measure whether people who said that they're going to do something to benefit health and social care actually do that. So just to ensure it's not too disappointingly aligned, Harvey Walsh, if you go and look in the nice web-based view of our data uses register, you can see the realized benefits, because every time an organization comes back for a new agreement or an extension of agreement, we ask them, what have you done with the with those things? Point to the benefits that you have delivered from the data that you've been able to access. So there is a list of things that have been done that's in the public domain.
But we want to agree on the customers, Michael, not a list of their customers.
There is room for improvement, and we're not all going to agree on all the uses, but it is there. I'll let Kelly come back, I think, on the IP bits, if that's okay.
Thanks, Michael. Yeah, Phil, I was just going to say I violently disagree with you. I'm sorry, not disagree, agree with you, completely agree. So that's it. That's exactly what we're doing, right? Cost-based, we can identify how much it costs to provide data access to the customer, and then sharing the value, exactly as you said, the financial value determined by two things, revenue royalties or milestone payments, the two easiest things for us to measure. So if you succeed and meet certain requirements, yes, absolutely, that's when we expect there to be a payment. Or if you sell a product for lots of money internationally because we've managed to support you with NHS data, then we expect a small percentage return. That is, as you said, very easily auditable, checkable, and that's exactly what we plan. So completely strongly agree with you. I think I also agree with you on the other point about the insights. What we're taking out is the insights, and I think going back to the title of this session today, I would say that what we're not doing is selling data. What we're doing is selling insights.
Well, at the moment you're selling data because it's going out the door. If in a TRE world, we can be selling insights. Yeah, absolutely. I think this is where this is why we're in a transition phase at the moment. Sorry, one other point which I think none of us have raised yet, but there is another way in which money gets involved in the TRE world, which is that some of the uses of data inside those trusted research environments are going to require that environment to be massively sort of boosted in capacity. Things to do with what's called machine learning or deep learning, what generally is lumped together as AI. Yeah, and we can't be sort of spending a whole bunch of NHS or public money beefing up this environment to do advanced sort of stuff like that. Yeah, so we should be actually charging people who want to do that sort of thing with the data that is in that environment for them to actually build up the capacity, and then that capacity becomes available to us all. So there are all sorts of, I think, potentially new interesting models. If you say we're not going to make copies of the data at all, it's all going to reside in this secure, what's called safe setting with all these rules around it. But then there are ways in which companies who are saying they're going to, like, well, a few years ago, we had DeepMind, a part of Google, come and start talking with individual NHS trusts, sometimes getting it badly wrong, like with the Royal Free London, but sometimes getting it actually really quite right, like with the Moorfields. And so we're going to need to have not just sort of, oh, we're providing a service here, come at us. We're going to need to actually say to people, in order to do this stuff, you are going to have to really quite significantly contribute up front in order that we all then can benefit. And this is the other thing, we can't have secret stuff.
Sorry, can I?
I think it's that, to be slightly irritating to the audience, we're just going to agree again. This is the difference between having the V&A and being able to wander around freely and having a special exhibition, which you might charge more for. Fundamentally, anybody can come into the museum and see the artwork. If you want to see a particular type of artwork in an exhibition, there might be an extra fee for that, but it doesn't stop the museum being a free piece of environment for anybody to come and access and use. But nobody's taking the art off the walls, fortunately. So I think there are ways to allow, but it's back to the idea that Michael had at the start. We're charging for the services associated with accessing the data, not the data itself. And then the data itself generates insight that we also want to ensure the NHS benefits from. So it's the outputs of the use of the data, and it's the ability to come and access it in the first place, not the data itself. Okay, we're going to go to a couple of the questions that we have in the Q&A. The most upvotes at the minute is a question about understanding of why some patients are worried about their data being shared. Do we have a clear picture of what they think, what might happen to them, to the data? Without this, we can never hope to persuade them of the benefits. And I think before I hand that over, I'm just going to say, I think there's no single answer to this, and this will not be agreed. It will change over time. It depends on the context. There's not going to be, this is where we are, this question has been answered, off we go. So please tell me what you think are the main concerns. And I'm going to put that to, sorry, Phil, you wanted to go first, yeah?
We've got good evidence over about 20 years. The two main things that really annoy people is if there is a perception that commercial companies are making a profit from something, yeah, and if people's permission has not been asked. Yeah, those are the two reasons why people opt out the most. Yeah, but you're absolutely right. This is about the choices of 50, 60 million individuals. No one knows what is in any individual's medical record, or shouldn't do, apart from themselves and their clinical doctor and clinical support. And therefore, you can't know why someone wouldn't want to share something. Yeah, as I say, the problem being that the data is at individual level, and while it is pseudonymized, it is still personal data. Therefore, claims that this is anonymous just have been wrong for years. The law is really clear, has been since May 2018. It's going to be in the first clause of the new Data Protection and Digital Information Act, saying pseudonymized data is personal data. That is why a lot of people have concerns, because people tell them, oh, it's fine, it's anonymous, then they find out it actually isn't. And, you're off to the races again. Yeah, so I say huge variety, but three main, top level reasons.
So Debbie, I think you're on mute, but I'm going to
sorry, yes, it's you.
So I think Phil's outlined some of this. I think what's been interesting to watch is the conversation around the environments or the way data is provided to or accessed is a big piece. So actually the shift from data sharing to data access is a key one, because it offers additional mechanisms to protect the data and keep it in one place, as well as being more transparent about how that data is being used. So I think the environment is a key variable, and actually it's talking about how we're deciding who uses the data much more than actually, I think, for whether it's selling it. So there is a conversation that we need to have around good research and innovation involves the private sector. If we want good new treatments and interventions for patients in the next 75 years, the NHS can't do it by itself. So there is a conversation about how we work collaboratively to get the kinds of outputs and impacts we want. And that can't just be done by just the public sector. So I think there is a bit about the perception of industry or innovators. There's also one that just, even when we talk about value doesn't seem to be seen by people in the same way. We've seen some interesting insights out of the recent surveys done as a consequence of GDPR, that certain groups, ethnicities and socioeconomic groups do not consider that value will benefit them or people like them. And that's a really important one, I think, for us to consider, that it's not just about getting as many people to opt in rather than opting out of data use. It's thinking about how we make sure that how we consider value is seen as impacting and supporting people of all ethnicities and all socioeconomic status. And that requires a different conversation. And then my final point is just to say, I don't think we need to convince everybody. We should respect people's individual preferences, and we should lay out the information clearly and be honest and open about what we want to do with data, but we shouldn't be trying to convince or compel anybody to share their data. If they do not wish to, we should respect that. I think it's on us to do a better job of explaining what we are doing and why we think it's a good thing. And that's part of the plans that are laid out in Data Saves Lives in terms of a new pact and a conversation with the public around data. But I think it is complex, but we should say it's okay if you don't want to, but we're going to do things because we think they're the right thing. And this is how we're going to try and make that as secure, safe and transparent as possible. And to make sure that we generate things that will help your children, your grandchildren and your grandchildren's grandchildren.
Yeah, I would violently agree with your last point, well, last couple of points actually. But that's why I raised this other stuff. We are muddying the waters and polluting things terribly. Just when we get to a point where we can actually sort things out, put stuff into the right environment, put the right processes around it, and we are allowing app developers to have advertising IDs in apps that we're promoting to to patients or all sorts of these other things. There needs to be a coherent conversation and understanding about finance and money around the NHS and digital stuff. There is no point just focusing on this one area, which, as I said, is an old conversation, which I think we're getting to the answers on. When you basically letting all this other stuff, because you'll just perpetuate the same problems. It's the perceptions that we are dealing with, and if the option that people have is something's happening, I get to hit a big red button, it's the perceptions of the entire thing, not what you've just done to fix the thing you broke last time, that is going to influence people's decisions. So that's why I would encourage certainly an ongoing conversation. I think we're getting close to some really good answers around this particular focused set of uses of data. But we need to really attend to the other stuff, because people perceive the overall actions and their experiences of and around the NHS. They don't get the privilege of a 3-hour conversation with Use My Data, where they can interrogate people on both sides of the argument, if there is both sides.
Okay, next one, question, it's about GP data access apps and what they're selling. Recognizing that GP surgeries are private businesses and that the NHS app now exists, should the government stop GP surgeries using non-NHS developed apps?
As I raised it, I'll talk about it. GPs are registered medical professionals. Your pharmacist, also a business, has to be registered under the General Pharmaceutical Council. Where are the app developers? What's their regulator? What keeps them honest? Because we've had people come in with business models since Pharmacy to You, where they were getting the data, burying the opt-out 3 layers deep in their website, and then literally targeting people with cognitive impairment for Australian lottery scammers. Okay, if we're talking about not being able to track the legitimate use of people who are coming to do stuff that's benefiting the health and care system, research, all this good stuff, and we're not actually putting limits around who can do what, with and around a patient who's basically just trying to get access to their GP record or make appointments or what have you, then something has gone terribly, terribly wrong. Now, we've been fighting in this area since 2015 on apps library, but I think it's something we need to attend to.
Okay, going to go back to Claire.
Yeah, just as I think this is a complex field, because you start to tread back into something I said before, and we have to accept that the public sector industry is part of how you get new innovations and new things into the NHS. We could still be using old X-ray machines with plastic films to look at the images if people didn't innovate and come up with new technologies. And I think so there's a piece about how do we work with the private sector to get good products that the NHS needs and are safe and are worthwhile for patients. And we do need to offer good advice to GP practices, to A&E departments, to ambulance services, to all of the system of the family of the NHS about what good has to look like, what are good products. But there is this balance of Individual choice, individual practice choice. I don't think we'd want Uber contracts from central NHS England that says you must all use this one solution, because local environments require the local context matters. So there's this tension about what do you do locally and what do we do nationally, and how do you find the right guidance in the system. So I think Phil's point is well made, and it's an important one that we think about what products and services are generated and how do we advise providers of NHS care on what solutions are suitable. And this is going to continue to emerge around AI, around new software products. So this is an expanding field that we're having to consider with the regulators, what the scope is beyond registered medical devices. How do we start to explore this? But as much as I accept Phil's point that we need to think about this in the round, we could also boil the ocean. And I think we need to take one step forward and resolve one piece and start to build out from there. I think if we try to resolve everything at once, we'll get analysis paralysis.
I'm talking about solving one thing. Put into the requirements for all app developers that they cannot use an advertising ID. Very simple, doesn't affect anything, at the GP choice end, the patient choice end, or anything else. But if you're going to put your app around the NHS, you can't use advertising trackers and advertising IDs. Doesn't stop innovation, doesn't stop creativity. They can
I get another question in before we break?
They have to do that.
I'm going to try and get another couple of questions in. Sorry to cut over you, Phil. We've got loads of questions in the Q&A. And one's really about language and chopping and changing. And I think this is a really valid point. There's a couple of questions about similar things. Using the term innovator for research data users, smack of commercial language. There's a lot of commercial commodified language around data, and we talk about assets, and that I have to say it's something that I'm a little concerned about. Are we using clear, good language that people can understand without making everything seem to be about money? And is it helpful when there's so much change within structures and acronyms, so TRE, SDE, Public Health England, NHSX, NHS Digital? What does this, how does this service, does it serve us well? Is there some way we can do this better? I think the answer is yes, but I will let somebody go first. Who would like to go first? Kelly, you're nodding, you're going first, I've decided.
I think I'm very guilty of this, and I think one of the reasons is because this is absolutely not what I usually do. I'm an economist by background, and I have worked in NHS policy for a number of years. And what I recognize is incredibly important that we work with patients to communicate what it is that we're trying to do correctly, but that we are not yet experts on doing so. So I would love to listen to people basically and say, look, we're trying to communicate really quite complex ideas here. How does it best work? We are talking about working with researchers, innovators, industry, commercial companies. Do many of those things mean the same thing? Probably. And we are talking about the commercial value as well as the literal financial cash in the pocket here as well. But how do we say this in the right way? So in short of it, I think I just agree with the question. We need to work on doing this better, and we would love to work with you on doing that, because it isn't naturally our comfort area.
Okay,
Can I pick up just a TRE SDE point, because I think this speaks to exactly Phil's point of TREs, or trusted research environments, was language that came out of the academic research community largely. What we did as part of the policy work was actually talk to the public and talk to participant and patient panels and said, saying trust on the tin doesn't mean you're trustworthy. So I'm skeptical when you use this. It's not just about research, because you told me it's about other things as well. So actually the shift from TRE to secure data environment was done because patients and the public told us they liked it better. So sometimes things are going to change because we're going to take on board the feedback from the patients and public. So you think it makes more sense like this way? Let's go with it. So that's a shift that is entirely reflective of public and patient perspectives and feedback we've had. I think there's another piece that's just, we have to embrace the fact that this is a complex space, that there is nuance, and the nuance between academic blue skies discovery research and phase 3 clinical trials by big pharma I could say they're all research and innovation, and a member of the public could say, nope, they're very different. So how do we have a conversation that allows for nuance, but doesn't feel like we're obfuscating and judging things? And I think that's tough, and we just have to say it is tough, and there is a lot of complexity here. And really to drill it down to what matters most, and therefore where does precision matter most?
I think it's right, and it is a highly complex area, and sometimes we oversimplify. Like, for example, in the National Data Opt-out, saying planning and research is now causing all sorts of headaches. Now you want to do a federated data platform that includes mostly planning uses, which turn out to include a bunch of stuff that doesn't look anything like planning. However, my suggestion on this one is, rather than, and I don't stop doing all of this talking with patients and focus groups and everything else, but take a population scale approach. Go back to our personal data usage reports. Yeah. Once you start showing people how their data is used, you have an entirely different sort of conversation. Yeah. You can talk about people's own stuff. Yeah. You're not talking about abstracts. You have many routes in which you can actually start to explain things in a much clearer, more meaningful way. Just the very fact that we're talking about an abstraction, data, being done with stuff which is hoping to do things in the future, innovation, even research, which, you know, good research processes find that negative results. Yeah, we need to be talking to people about their data, and that means providing them the evidence of what is being done, and then wrapping explanations around certain things, so that, you know, dribble by dribble by dribble, you know, people begin to learn and be educated about just exactly what the full range of things is that the NHS and others do with our data.
Okay, in the interest of time, I think we need to take a break. Am I right, Chris?
Yeah, yes.
We have loads of questions. They will all get answered. Probably not today, I'm going to be honest. But I think we need to take a break now. Joe, do you want to say anything before we break?
I think just, you know, there's been brilliant discussions, I think, today. You know, the community that I'm representing is from the sort of rare disease background, and I think that just puts a whole nother spin on, you know, how data is used, consent for the data, you know, just the value, you know, in order to help future patients is you know, is quite intense. So no, just to say thank you for everyone's thoughts today.
Thanks, Joe. Okay, look, we're going to take, we're due back at 3:30, is that? Okay, so this is the second part of the webinar, and really what we want to do is look across some of the UK. We're not able to look at Northern Ireland at the moment, I'm afraid. But we're going to also look at what happens locally. So it's in a large hospital where data is generated and where the data is used, and also some thoughts from the National Data Guardian. So first of all, we're going to listen to, David Ford from Wales, and then Roger Halliday from Scotland to speak about their work. Okay, so David, are you ready?
I think so. As ready as I'll ever be. So
okay,
thank you very much, Debbie. Hello, everybody. Difficult to follow a really good discussion as we just had this earlier on. I'll try and be brief so that we have time for more discussion afterwards. So I'll try and keep it snappy if I've got this right. So my name's David Ford. I'm director of something called the SAIL Databank. You may not have heard it. It's established its reputation in Wales, and we're talking primarily about our work that we've been doing with Wales for really quite some time now, although we do actually operate and provide the similar sort of services for pan-UK exercises. So we claim on our website that we have brought together amongst the richest population data in the world, and that's principally because we aim to accumulate data from across society through a range of public services that support members of the public. So not just health, although we cut our teeth in healthcare and still is the largest, perhaps, fraction of our data users, but we do accumulate and link data from all parts of government across Wales. And we take data privacy and security very securely, and I think we're the most accredited organisation in the country doing this kind of stuff, mainly because we've been around a long time. And it goes without saying that to do that, we have a large number of very expert people working in our teams. So we only have one mission, and that is to make data work hard for public benefit. No commercial imperative, no hidden research agenda, just this one mission. That's to take data that was produced for lots of good reasons as part of operational processes and to put it to good use for a public benefit. And because we do this as a neutral organisation without an agenda or any allegiance to any governmental body or anything else, we are totally focused on being responsible and accountable to data owners because they entrust their data with us. And so they, we clearly have to be very responsible with regard to that. But almost more importantly, to the members of the public to whom the data pertains. And we spend a lot of time and energy trying to make sure we do a good job on their behalf. And of course, therefore, gaining and sustaining public trust across Wales is our #1 priority. We've been around more than 15 years as an operational unit. As I said, we're based in a university, and that comes with some pluses and minuses. I mention one or two of those in relation to the sort of the money side of things, but it does mean that we don't owe anybody any favors. We don't have any obligations. We simply have to do the right thing with the data that we are able to acquire. We are completely not for profit. Cost recovery only, and that comes with some challenges as well. I shall briefly mention that. And we've been around for 15 years within a university as a self-sustaining unit, and that means we have to work really hard to make sure that we do balance the books at the end of the year. So we are a good example of how much it actually costs to run a unit like ours. We work hard to be a lean organisation, and as Phil was saying, we rely heavily on technology to do that, to do a lot of automated tasks behind the scene that people otherwise have to do. And we're fortunate in running our own technology set called the Secure e-Research platform, which SAIL can benefit from because it's used by a wide variety of other organisations across this country and across the world. And that defrays the cost of development and supporting the technology set. We work hard to involve public throughout our enterprise. So we have standing panels that sit and scrutinise everything that we do. Members of the public are involved in every single decision about what project goes ahead or what doesn't. And we conduct routinely large-scale consultations, both at a community level and also centrally, on issues that we are uncertain about and need advice. All our data is fully de-identified and linked automatically, and I could have described how we do that, but essentially what we're able to say, we're able to look anybody in the eye and say we have no names and addresses or other commonly known personal identifiers in the SAIL databank, and never will have. Clearly, as Phil has attested, that doesn't mean to say that this data is not personal, and doesn't mean to say that it's not sensitive. We treat it as if it was personally identifiable, but we simply do not acquire names and addresses. We use a third party to process just names and addresses for us, so that they don't see any sensitive data and we don't see any names and addresses. We were the first UK organisation in the UK to operate what is now called a TRE or an SDE. So we've been running a no data ever leaves environment for over 15 years. And that means that all the research that is conducted on the SAIL Databank is conducted on our platform, on our compute facilities. And as a consequence, we can see absolutely every mouse click and every keystroke that is being used on that data. We can delete the only copy at any time if we need to. No one's ever asked us to do that, but we could. And it comes with a great deal of many benefits, as Phil was putting forward. Researchers get access to the data they need, and no more and no less. So there's 100 billion records in the SaIL Databank or thereabouts. No researcher ever gets access to all of that. So they get a view crafted on their research proposition, just the data they need, and they get a view of that data when they enter our platform, and no more. All projects must pass a public benefit test, and this is a tricky one. So we don't attempt to ascribe a value to that benefit. We just simply look to see, is there one? And I say we, because actually we don't really do that. We do kind of filter it, but actually there's an independent panel, we call it our IGRP, which is made up of ethicists and scientists, some data guardians, and importantly, a third of members of the public. And they make every decision about whether a project should go ahead or not. And part of that decision, they look at privacy risk and potential for that sort of thing, but they also look to see that there is a discernible public benefit. And there must be a kind of plausible route to that public benefit described as well. It doesn't discount us doing work with and for commercial organisations, but we're less interested in shareholder benefit. We're only really interested in the public benefit. And if the public benefit, a direct public benefit and a route to public benefit can't be described, the project doesn't go ahead. There's about 600 different organisations around the UK, many of which are in Wales, but not all, that routinely share their data into the SaIL Databank. So it's quite a busy environment, lots of data coming in on a routine basis. And on average, there's about 200 individual projects that are ongoing on the using bits of that data, with about 500 odd users logged onto our systems at any one time, analysing that data. And as I said before, it goes far beyond health and includes courts and schools and local government, central government, and lots of other stuff besides. And we take pains to make sure the users are all vetted and trained under contracts. Now, keep doing all this, keeping all this data safe and linking it all together, because that's essentially what we do. We're a data linkage outfit, and making it usable. That's not a simple task, because this data is not easy stuff to use. It all takes a lot of time, expertise and money, and surprising amounts of it. As I mentioned before, using technology well helps the cost down, but you still need good staff, people that really know what they're doing, that are highly expert, highly responsible. You still need to refresh technology and update it underneath it all. Luckily, actually, our university, I don't think it actually knows this, but it pays for our power and our lighting and heating and stuff for this. So I guess we're not that self-supporting in that sense, but and our electricity bill is really huge, but they haven't noticed, so don't tell them. That would be helpful. Our kind of stability model is we get modest flat core funding from the Welsh Government. They gave me a small grant in 2005 to kick off this work. They've given me that same grant uplifted a little bit for inflation over that period. It now accounts for a very small fraction of our turnover, but it is useful and it's stable. We've also benefited from long-term investments from, and I apologise for the acronyms, it's very rude of me, but I couldn't think of a way of writing them out in full without boring you to tears. So this is the UKRIs, the UK Research and Innovation organisation, which represents the collective of research funding bodies in the UK, of which the Medical Research Council and the Economic and Social Research Council, which you will see acronymized there, are some. And we've received over the years substantial support periodically from both the Medical Research Council and the ESRC, Economic and Social Research Council, which we're currently still benefiting from. We also participate in sort of large programs of research with academic colleagues around the UK, and that brings us long, thin contributions to our running costs. In other words, it's sort of not huge amounts of money in any given year, but sometimes it lasts many years, and that helps us kind of stabilise the boat. And on top of all of that, and importantly, we charge all of our users to access the data bank. So they are very much, as we heard with NHS Digital, there is a costing formula. It is entirely driven by the amount of effort that we need to put in, with a small contribution to the running cost of the technology which they were going to consume within their project. And that varies considerably across different projects, particularly that some projects are, and the people within them are more expert than others and would need more hand-holding than others to execute their studies successfully. The public sector people that, from the NHS and government that use the Cell Databank, and the academic colleagues benefit from discounting, which we apply to take account of the fact that we get this core funding from both Welsh Government and from other public agencies, whereas commercial companies, of which we don't really work with a huge number, pay the full economic cost. Just a word about full economic costing, because if you're interested in accountancy, and it's not terribly exciting, universities are bound by a kind of a government-controlled formula for calculating what their cost base are, and it gets used when you put a research grant in or something to allow for other non-specific costs to be included in a research grant. And we use that same mechanism to calculate how we cost out our time and energy in supporting the research projects that apply to us. It's very good. It keeps you completely honest. You can't dodge it. The downside is, I suppose, in many ways, is that you can't bill for 100% of a person's time. You can't sell the thing twice. And so it is actually, whilst it keeps us completely not for profit, it does mean actually keeping the show on the road year on year is really quite difficult, because there's no way we can accumulate a surplus to tide us through. So yeah, I'm not going to cry on your shoulders, but it is a challenge. But it does mean that we can, hand on heart, say we are for cost recovery. And then finally, I'd just say, in the vein of the conversation that we've been having this afternoon, that charging and getting cost recovery is important to us, but actually demonstrating value is really important. And I used the word value in this slide before we had the conversation. And had I chosen to heard the conversation before I wrote the slide, I might have not used the word, because it's quite a loaded word, isn't it? And it does bring with it a connotation that somehow there's a pound sign involved in the equation. From our point of view, the pound sign is largely irrelevant. We don't look for monetary benefit from the work, but we do look for, as Claire mentioned, impact. We want to know what the consequences of the studies that have been executed on the Cell Databank are. And as Claire also pointed out, it's really hard. Most of the consequences, hopefully beneficial ones, will have accumulated long after the researchers have done their work in the Cell Databank. They can only take out the artifacts of their analyses, graphs and tables and so forth. But once they do, they're more or less, and they've been checked by us that they're non-disclosive and they conform to the application that they put in, then they can go off and do more or less what they want with those. And obviously they're very keen on doing good things and seeing good consequences occur. But we have to spend time and energy chasing them. I've got a little team that does nothing else but chase these people. So what happened? What happened next? Is there anything that's good? Because from our point of view, looking the public in the eye, as we do every single day, and saying, this is doing a good thing, we're being very responsible and safe with your data, is not a complete sentence until you also can say, and good things are happening and it's worth it. And we're putting as much time and energy as we can into doing that. And there are some examples in our work in progress website that you might want to go and have a look at. So that's me done. I'm happy to take some questions at any point, but I suspect that'll be later on in the proceedings.
That's great. Thank you, David. And I think we're just going to go straight over to Roger.
Okay, yeah, I'll just try and get this things set up. Okay, brilliant. So thanks for inviting us this afternoon and allow me to be involved in this debate. I'm Roger Halliday. I'm the chief executive of a new organisation called Research Data Scotland. And actually, our story is pretty similar in some ways than David. So I can skip over some of the things that I was going to say, but we're at a different point in our maturity. We were set up last year as a charity by Scottish Government, by Public Health Scotland, and we're owned by various universities, Aberdeen, Dundee, Edinburgh and Glasgow, to do exactly what David and others have been saying, to create value from data about Scotland's people, places and businesses. And I've worked as times as an analyst and researcher in the NHS, but over the last 11 years or so, I've worked as Scotland's chief statistician, covering all aspects of people's lives by insights through trustworthy data. And while all I'll say will cover a work on healthcare data, what I'm talking about here also covers other aspects of public life as well. And by data, I'm talking here about data related to a specific person, place or business, rather than aggregated data. So for example, averages over a local authority area. So, and that data, as David said, is personal data, but in the same way that we have in Wales, nobody from a researcher to the operators of the trusted research environment that we have here in Scotland can identify an individual from the data that's held. And the other thing I would say up front is that decisions on the workings of the NHS and social care, such as kind of what happens with the data, is decisions taken in Scotland by the Scottish Parliament, though some of the underpinning laws around data protection legislation are UK-wide. So I'll just say a little bit about our approach in Scotland to creating value with data, and in particular how these services are funded and our engagement with industry. But first of all, just something about the value that I think we can create here. These are sort of areas where that I see researchers and analysts across Scotland creating value with data. So it helps tell government, helps tell public sector organisations whether what they're doing is working, and if it's not working to best effect, how to do things better. And the fact that it's individual data helps understand better that to get down at what are the causes of issues. So, for example, in COVID, linking census data with health data and vital events data helped really understand the characteristics of people who had different levels of risk to COVID, and help target government policies and policies in the NHS to better support people. Helps people that are using multiple services. So we've done a big study in Scotland around homelessness and improving healthcare services for people that are homeless, and that involved linking data from local government about people that became homeless and data from the NHS. And then also some of these other aspects as well, in particular, kind of those impacts across different parts of society. One of the key principles of Research Data Scotland is not just that it's in the public good, but it helps illuminate the issues around equalities in society. So one of the things that we have done is built up a much richer picture of the data that we've got about some equalities, protected characteristics for people for use in research. And the idea is to support public bodies by getting much better quality equalities data to help them improve their services directly and make sure that they are properly inclusive and diverse. So this is a vision. It's similar to what is described elsewhere within the UK. And we're working with expertise that are on tap because we're, like I said, Research Data Scotland, the organisation, has been set up for a year. However, we're building upon a level of expertise that exists within Scotland. So some of our colleagues in Public Health Scotland have been providing a similar service to that others have described in a trusted research environment setting around access to data for around the last 10 years. That we use expertise in an organisation called the National Records of Scotland that do they record births, deaths and marriages, and so they've got a pretty good idea of the population. They've got expertise in connecting people in secure ways between different data systems without revealing anybody's identity. And we work with an organisation called the Edinburgh Parallel Computing Centre, which are part of the University of Edinburgh, and they've got 40 years worth of experience in secure computing environments, and they host our trusted research environment, the space, the secure space for doing work. We also work with organisations, and we have a role in trying to align approaches to use of data with organisations that are a part of or are partnerships between academia and the NHS in Glasgow, Edinburgh, Dundee and Aberdeen. And that we work also with UK-wide organisations, because some of the data about Scottish citizens and places and businesses is captured at a UK level. And so at the heart of this goes back to the conversation that we had, that fundamental to all we do is about embedding public engagement and involvement in our work. And I think what we've found is that the public's in general supportive, and I'll come on to one of our principles that extends this, but as long as these three things are met, that there's a clear public interest, that the data is being held incredibly securely and in trustworthy ways, and that all we do around our processes and around who's using the data is transparent. And one thing that I would just talk through very briefly is actually what happens currently, and this is a sort of convoluted process. I think I'm not quite sure if it's exactly like this in England, but of actually getting hold of the data. So a researcher comes along with an idea. They have to track down the data that they might find useful, and until recently that's been quite difficult. They have to then go and investigate the legal basis in which they could use that data and find out the quality of the data. Is it actually good enough to do the kind of research that they're looking for? Then they develop a proposition, try and persuade the owner of the data to share that. Then there's an independent scrutiny of whether that's likely to lead to value in a similar way that David described. The data is then encrypted to preserve privacy, and it's transferred into our, we call it national safe haven, this trusted research environment, and the researcher does the analysis, and then it's manually checked to make sure that no inadvertent sort of dissemination of those the outputs happens. But there's a lot of places where this can go wrong, and it generally does. And on average, and this is the average, it takes about 208 days from the researcher having an idea to the space where they can actually start on the looking at the research. And we're aiming to maintain the security around the data, but do a lot of the preparation upfront. And I think this is to take us into the space that David described, that they're in Wales in a more mature an organisation that's been around for a lot longer. We have a set of core principles governing the setup of the way that we're operating, and so you'll see there that having the data not leaving that safe place, and that nobody, no researcher and nobody in the system can see the identities of the people and the businesses, and that transparency. And then just as happens in Wales, all the income that we get, because we need to charge for some of our services, and I'll just talk about that in a second, but any income gets reinvested directly in the services, so it's paying for that level of expertise in holding data securely and making it available in secure ways. And we're working to support people's control over the use of the data and research. And yeah, so we can maybe get into some of that in the Q&A. In terms of who pays for these services, well, we're in a relatively lucky position in that the government in Scotland has chosen to invest in setting up an organisation such as Research Data Scotland, and underpinning a not insignificant amount of the costs of the system. And that comes from their experience, certainly in the COVID pandemic, when they saw what a difference actually being able to connect data can make, and make it available responsibly for research. So the effectiveness of the vaccines would be one example of some research that influenced government decision making there. And then the rest of the income is that we have a number of large scale research programs, and David mentioned a couple there that we're also involved with. But there's also the other big chunk is one-off research projects. So this is typically where academic teams that come along and want access to data, that they get research grants for their work, and what they do is they add in the costs of the data preparation and all of that into research grants. And we have got a pricing policy around this. So we charge less for NHS and public bodies, and we charge a bit more for academics, and we charge a lot more for industry. Not that there's really very much work from industry at all at the moment. And these arrangements have been around for some time, and recognise that they do work for some research teams, but they don't work for others. So a PhD student that is doing some interesting research finds it quite difficult to get grants to pay for this. So we're just going to review how we charge for those one-off projects going forwards. And then finally, the last thing I would say is about working with industry. And say that this isn't much of this that happens at all in Scotland at the moment. And I think part of this is that there's no public agreed policy statement of how we'll make this work. So the Scottish Government's putting that right at the moment. They've got an independent review that's looking at a statement of how work with industry on public sector data will work for healthcare and for other data, and that they've come up with a set of draft principles that are around public engagement, around making sure that the public interest is sort of key, and that doing no harm and acting in precautionary ways, making sure that until there's absolute clarity about that route to benefit, that the industry will not be involved, and about transparency. So this is the aims to have these things in place by the end of this year, and then to use the high level policy statements to develop approaches to working with industry in due course. But we need to solid ground to start off with.
Sorry, Roger. Thank you so much for that.
That's me finished. Debbie, perfect.
Thank you. I'm just going to push on now because we've got quite a lot to get through in this part of the session as well. So I'm going to go straight to our next speaker, if that's okay. I'm going to ask Jeff if you would like to, if you're ready to talk. He's going to talk from a slightly different perspective, which is that of a lead clinician in a large teaching hospital. Okay, Jeff?
Okay, thank you very much, everyone. It's a real pleasure to join this conversation and particularly to follow people who have influenced and guided the approaches that I have been driving in Leeds for some years. So my name is Jeff Hall. I'm a medical oncologist in Leeds, and I'm also a professor of digital health and cancer medicine at the university. But I have some other roles, and I'm the Chief Clinical Data Officer at HDR UK. So HDR UK, Health Data Research UK, is the UK research organisation that focuses on the use of health data. And within my role at HDR UK, I'm a clinical lead for something called DataCan, which is a hub that focuses on the use of health data in cancer patients. So this is the vision on a single slide for DataCan, set up 3 years ago. With a vision to improve access to data. We were established specifically to support clinical, academic, and commercial partnerships. So we aim to bring data together, which could more accurately portray the full care record of a patient. So not just structured data from a clinical record, but the content of radiology, digitized pathology, results of genetic and molecular testing. To do that at scale, to do that across the UK, the 4 nations of the UK, and there again, the phrase that a number of people have talked about, ensuring fair value. So that was a partnership set up with UCL partners in London, the University and Hospital in Leeds, Queen's in Belfast, Genomics England, and then at the bottom you can also see the IQVIA logo, a commercial organisation, because a requirement of receiving this funding was to bring in a commercial partner to work with. Some of the work that we've done within DataCan is absolutely not driven, supported, or guided by commercial organisations. And DataCan was one of the organisations that reacted and responded to COVID. And we were the first group to describe the impact that COVID was having on cancer services in the UK. So we very rapidly brought together data from a number of hospitals and could demonstrate the profound impact that the COVID lockdown was having on urgent referrals to cancer and also the treatment of cancer patients. We looked at chemotherapy data, and from that began to project concerns about an excess risk of death that would occur in cancer patients, both from the direct impacts of COVID and perhaps COVID plus a patient's comorbidities, but also from the indirect effects, the negative impact of not seeing cancer patients, the negative impact of stopping cancer screening, the negative impact of delaying cancer diagnosis, and therefore treating people at a later stage. So that is work that DataCan has been doing, absolutely not within the commercial domain. But here is an example of one of our commercial partnerships. This is work that we describe as a deep dive curated EHR. And in the earlier session, a question was raised about the quality of data in the national data sets. So that's absolutely relevant to this work. And we in Leeds have led work with other colleagues around the country where we asked the direct care team to review the case notes of relevant patients and to make their data perfect in their database. So that's a process that we describe as curation. We all agree which data items we're going to collect, which data items we're going to make perfect. And then the centers together will work out how to share that data between those NHS providers to perform the analysis. And we've done projects in breast cancer, we've got prostate, multiple myeloma studies going on. And on the right-hand side is an example of one of our outputs. And for those of you with very good eyesight, and I don't know if you can see my mouse tracking, but there is data hidden here. So small numbers, less than 5 patients, we would never release that. That's considered potentially identifiable data. And therefore we would hide that as just being less than or equal to 5 in an attempt to ensure that we're always protecting patient security. So on a slide here are the core principles, the red lines under which we would work within DataCan with commercial organizations. One of the things that DataCan has been very committed to and very strong on is its patient and public involvement and engagement. So patient and public members are on the management group of DataCan. They actually have 2 representatives where everybody else has 1 representative. And in a decision regarding a commercial partnership, they can never be outvoted. So it's not that if all the academic centres voted together, we could outvote the 2 patients. If we don't have the support of the patients and public representative, the project does not happen. All work we do will always respect any national or local expression of a desire not to be involved. Without question, we will never challenge that. We would just always respect that. And the data that we use, although kept within the NHS, is always de-identified. And then this other word, minimized. And I think David suggested this phrase that we will only release data that is needed, no more, no less. So the classic thing projects ask for is a date of diagnosis, a date of recurrence, a date of a treatment. They absolutely don't need that. They need a year of diagnosis and a time to an event. And from that, you begin to increase the protection of identity. And we will never share the patient level data with the commercial organization. We will perform the analysis for the company according to the analysis plan that the company would like us to do, but we would never share the patient level data with the company. So we would share the aggregated data in the analysis. We would always hide small numbers. We're increasingly going up with the numbers that we would obfuscate. And on the right-hand side, critically, everything we do is placed in the public domain. So we would publish in the peer-reviewed literature, we would present at public meetings, and where the work is perhaps not of that great higher impact, we would put the results on a public-facing website, so the results can always be found. And we've always refused to do anything that gets anywhere close to exclusive work. So if a company asks us to do a project and then not share that data with anyone else, we will absolutely refuse. And there are companies that have offered us more money to do the project if we won't tell anybody, and we have always declined that additional money. Once again, here's a recurrent phrase today, fair value. We would always work to ensure fair value, but I think the honest answer to the question, the exam question today, are we selling data? I actually agree with Phil. I think we are exchanging a service and an insights of data in exchange for money. And I think that that does in some way constitute selling data. So, I think it's important to be open and honest, but to articulate to patients and the public the red lines that we would do. So the comments that I've made so far very much reflect the views of me and a whole range of colleagues that I work with. But I thought I would do a final slide where I would take the logos off. And therefore, I must state that these are my own personal views, and I'm not committing anybody else in HDR UK or DataCan to these views. So I've done oncology, cancer medicine for 30 years, and it's really hard to get it better, to cancer care better. And we need to do that in partnership. So this clinical, academic, and commercial partnership concept is absolutely critical. I don't think data privacy is something that you do right or wrong. You just must always strive to do it better. So we need to do it better today than we used to do it yesterday, and we need to do it better tomorrow than we're doing it today. And I don't know what this is going to look like in a year, 2 years, or 5 years' time. I just here publicly commit to doing it better than we do today, not because I think what we do today is wrong, but we will always try and do it better. We will take the feedback that patients and public have offered us, that imposing a 10 to 15 minute conversation in a 20-minute consultation with a patient to take formal written informed consent is intrusive and potentially unaffordable. We would estimate that taking proper consent from a patient costs in the range of £400. We see something in the order of 50,000 cancer patients a year. So we're talking millions of pounds to formally consent patients. And as has also been raised today, there's a very broad range of views here. There are the passionate advocates who literally are outraged that we are not doing this. And there are the people who are vehemently opposed to the use of their data in this way. And we somehow need to respect and reflect the range of views. So I think absolutely every patient whose data is used needs to be directly informed that their data is going to be used in research. So the idea of a fair processing notice buried on the 5th level of a website is not acceptable. The more contentious the project becomes, the more important this becomes. And that's absolutely where we'd start individually writing to patients to tell them that this is what we're doing and that the mechanism to be excluded is to ask to be opted out. And everybody needs to understand this is a personal choice. If they don't want to do it, that is fine. And we will not question that decision. But if actually they'd just like some more information to help them make the decision, then we're happy to help and provide them with that. But I think Phil referred to this earlier. I do see a vision of the future. We live in a world now where we can communicate with our patients digitally. And those digital platforms, patient portals, which allow my patients to have access to the dates of their appointments and the letters and the results of blood tests, is also a perfect platform on which to seek patient support. So actually to go further than recording an opt-out, but to potentially record an opt-in, to go to digital assent, which is perhaps a lower legal standard than formal consent, and also something that the NHS couldn't begin to afford to do without digital tools, to keep asking, is it still okay that we use your data? You said yes a year ago, but we're just checking that you haven't changed your mind. And then Phil has also referred to this. We need to use those same digital tools to feed back to patients. Oh, your data has just been used. Thank you for letting us use your data, because you've just been one of the control patients in a study we've done for the impact of COVID on cancer. Thanks for your help. That's really useful. So hopefully I've given you an outline of what we're doing today, and hopefully I've given you some vision of the way we hope to do it in the future. But I'll pause there and send you back to Debbie.
That's brilliant. Thank you, Jeff. That's, I thought, really fascinating. There's some really positive thoughts there that you've articulated. So thank you so much for that. Joe, have you anything you would like to, is it unfair to ask you to talk after, to ask a comment after 3 speakers?
No, that's fine. Yeah, sorry, I'll just bring them up if that's okay. I mean, just on David's question, on David's talk, sorry, how close are we to sort of having a patient report to see how the data is being used so far? Because I picked up that you've been running for quite some time.
That's a good question, but I'm not entirely sure I know what you mean. So we have an embryonic kind of a data use register on our website, which says where all the data is being used, and that is going to become much better over the next few weeks. But I think what you might be talking about is a mechanism by which an individual could be able to know which studies his or her data has been used in. And I as an aspiration, I applaud that. For me and my outfit, we just can't do that, because we take enormous pains not to know whose data we've got. And then for me to be able to tell someone who what data's been used where, I'd have to know who they were, and that would completely break every single rule in the book in the way that we operate. So it's not beyond the possibility that something in partnership with the NHS and all our data suppliers could not be engineered. But at the moment, it's in the too hard box, even though I get the rationale for it and it would be nice, but I just can't do it.
Lovely, thank you.
Okay, so shall we move on to the next speaker now? We have Vicky Chico here. So are you ready to go, Vicky? She's speaking from the Office of the National Data Guardian, and it is, have you got your slides ready? Yeah.
Emily's going to present my slides for me, because I'm on a Zoom browser and it kicked me out every time I shared the slides. So thank you, Emily. Thank you very much. So I'm Vicky Chico. I'm the Senior Privacy Specialist at the Office of the National Data Guardian. And what I want to do today is talk to you about some empirical work that the National Data Guardian did, looking to pour content using public dialogue into the concept of public benefit. And I want to relate this empirical research that we did on public benefit to this debate around the distinction between fair returns for the NHS and perceptions of the NHS selling data. Next slide, please, Emily. So what I want to cover in this is firstly the evidence that there's over a decade of evidence, and this was also shown in our public dialogue work, that evidence of public benefit is an absolute non-negotiable for the public when access is to health and data collected through the provision of health and social care. And secondly, that people do see the NHS benefiting as a public benefit. And again, that's quite an overwhelming finding, but it becomes very tricky to define that benefit to the public if we're talking about a benefit that's a financial return to the NHS without further delving down into the nuance of that return. And then one of the key findings, and I think this again echoes other empirical work, that the evidence demonstrates that transparency is a key requirement. It's not an additional add-on or a nice to have. It's key. People need to be able to see how public benefit is evaluated and how transactions are made within the NHS in order for them to perceive public benefit and for them to perceive that fair partnerships that are being entered into are fair. Next slide, please, Emily. So our empirical research into public attitudes found that attitudes to secondary uses of data collected during health and care demonstrates that people overwhelmingly expect that the data should only be used in ways that benefit the public. The literature and our public dialogue work found that people are actually readily prepared to perceive benefits to the NHS as a public benefit. They actually felt that the NHS should receive something in return where it provides data for an initiative that then goes on to produce profit. And this is a common theme in the literature exploring public attitudes to the use of data collected through health and care. But it isn't clear that that purely financial benefit, without further evidence of service improvement impacting well-being, is enough to be sufficient to be perceived by the public as a benefit. We've also done previous research that showed that these views do hold. We've talked a lot about anonymous data today and how that's dealt with differently, but people's views about public benefit also hold for anonymous data. They think that data that's collected through health and care provision, even where that's rendered anonymous, people don't want to see it being used for uses that go against their perceptions of public benefit. And this is interesting because the usual protections around public benefit, like we might see if the Confidentiality Advisory Group considers an application to use confidential patient information, or the Health and Social Care Act requirements around public benefits to the NHS, and iGuard, who consider applications to NHS Digital for data. Those kind of safety mechanisms aren't there around anonymous data that falls outside the legal regime, and neither are the same transparency requirements that we see, for example, in data protection legislation. But nevertheless, we know that people do still care about how anonymous data is used. So in terms of maintaining public trust, we should also make sure that there are safeguards around that kind of data to ensure that it is being used for public benefit. So the interpretation of public benefit is a criterion in determining whether people perceive a fair return to the NHS for its data as the NHS selling data or as the NHS receiving a fair return to data. It seems to be one of the key criteria. And our public dialogue project does go a significant way to pouring content into the concept of public benefit. This guidance will be hopefully published before the end of this year. And like I said, it's very much based on public dialogue, and a number of the organisations that are present here today have fed into this guidance. And it pours content into the concept of public benefit, and particularly it does reflect how people interpret benefits to the NHS to be a public benefit. But I do think that there is some scope for doing further investigation of very tricky issues about the nuanced criteria for determining whether a financial return to the NHS is deemed to be for public benefit, and how we need to kind of drill down into what additional criteria people need to see in terms of the NHS benefiting financially. Next slide, please, Emily. So how does the public benefit impact on whether an agreement is a fair partnership or is the NHS selling data? I think there are probably three key questions which arise if the NHS stands to benefit from a project that need to be teased out to distinguish between a fair partnership and the NHS selling data. So the first question is the financial return to the NHS sufficient, or does the NHS need to show that the financial return will lead to benefits for patients in terms of service improvement or outcomes improvement? So that clear impact, it can't just demonstrate that it's benefited financially, it then needs to show how that financial benefit will be interpreted in terms of clear outcomes for people's well-being. And kind of following on from that, is a financial return to the NHS enough for people to accept that a data used by a commercial organisation that pays for data is for public benefit? Or does the end of the purpose of the data in and of itself need to demonstrate independent public benefit? So I'll talk about that shortly when we talk about things like insurance companies accessing data or organisations that might do things like direct marketing if they're going to pay for that data, but the actual project itself is not seen to have public benefit. This seems to overshadow people's views of any kind of return to the NHS. And then what also feeds into this kind of debate into whether people perceive the NHS to be selling data or receiving a fair return is what's acceptable regarding return to the NHS. And I know that Kelly and Claire spoke a lot about this in the first session. But the issue here is that there are concerns around excessive profit to commercial organisations, excessive profit to the NHS, but then also insufficient profit to the NHS is also relevant. So I have some sympathy with the Centre for Improving Data Collaboration in terms of how, sensitive and nuanced that is, because, if on one hand you're saying if profits are excessive, then it's selling, but if they're insufficient, then that precludes it being a fair partnership for the NHS. And I know that Centre for Improving Data Collaboration work on fair value framework is considering these kind of thorny issues. So I think there could be some deeper analysis of these issues in terms of determining where on that spectrum of selling through to fair returns, where does the project sit when we delve down into those nuances. Next slide, please. So the narrative around the NHS selling data doesn't sit well at all with the public view that we've reflected and that we think is reflected through around a decade of research, that public benefit is derived where the NHS receives a return for the data it provides to projects which actually make a profit. And headlines around the NHS selling data, they do receive a very negative public response. And any messages around benefit to the NHS to receiving a return for its data asset are lost in that narrative. The NHS receiving benefit for use of its valuable asset and the NHS selling data, I think, do sit on the same spectrum, and disentangling these narratives does require us to delve deeper into the three questions that I presented on the previous slide regarding that nuance of public benefit and return to the NHS. And one of the key things is that we have to be transparent about those uses and how we evaluate public benefit in those partnerships. Next slide, please. So thinking about how we might prevent the data selling perspective, there are three issues, I think, that lead to a perception that the NHS is selling data rather than engaging in a transaction that with a commercial organisation for which it will receive a fair return. One of the first issues is where the project's not perceived to be for public benefit. And I think the problem here is with trying to convince the public that the NHS is not selling data but engaging in fair partnerships does just rest on some historic and some current failings in ensuring that uses of data are for public benefit. And I think Phil outlined some of these in his presentation. I mean, there will be a number of red line uses to using health and social care data, but I think we have seen from research done by the Wellcome Trust that people are absolutely see a red line around sharing data for marketing purpose, sharing data for insurance. So it seems that this kind of project, even if it does provide a return for the NHS, is not sufficient to be seen as a fair return, and would be seen by people as purely selling data if the NHS got a financial return. And we do know from 10 years ago that the Partridge report uncovered this kind of sharing with insurance companies. And we do hear at the National Data Guardian quite regularly from frontline clinical staff who are being offered payment for providing their data to be involved in initiatives with private companies. So this isn't something I think that, you know, we can say it is not happening, but if we do want to avoid that narrative around selling data, we just need to make sure that those kind of things are not happening, where that clear kind of public benefit is not there. If people are to view NHS partnerships with industry as fair partnerships that proportionately recompense the NHS for its part in providing data to projects in the public interest, which also make a profit rather than the NHS selling data, we just need to make sure that these particular uses don't occur. Secondly, the perception that the NHS is not in a position to negotiate fair terms. UPD, Understanding Patient Data, and the Ada Lovelace Foundation found in 2020 that fairness is a key criteria which determines people's attitudes towards whether a partnership between NHS and commercial organisation is acceptable. Where there's a perception that the NHS is at a disadvantage in a commercial partnership and maybe receiving a return that doesn't reflect the value of the data, people's perception of whether the project is a fair agreement is affected. So it needs to be clear to the public that the NHS does have the ability to negotiate those fair terms, and it's not allowed to be disadvantaged or locked into exclusive agreements that are not in the public interest. Next slide, please. And then lastly, the just irreducible importance of transparency in ensuring the benefits of a project and the fair terms it's negotiated on are clear. We need to have communication that's clear and understandable to the public. And as I said, the empirical literature has consistently found that transparency is critical. People need to know what purposes the data is used for, and how benefit is evaluated and measured before they can actually perceive that benefit. But I think this is very difficult, and hopefully the guidance that we've written will help organisations who are grappling with this difficult question of how do you actually interpret public benefit in a kind of meaningful way, given the multitude of different data uses. But without this kind of transparent communication about partnerships and about how public benefit is evaluated, people think there's something to be hidden, and they're concerned around things like backdoor deals. And within this, we think the role of history and track record is incredibly important in determining how the public feels about NHS partnerships. There are a number of organisations perhaps that the public feel more distrustful of, and making sure that organisations that the NHS partners with share the same values as the NHS, I think, is a key issue in earning that public trust and demonstrating to people that the track record of the company is consistent with NHS values. Next slide, please. So thank you very much. Hopefully this has whetted everyone's appetite to see our public benefit guidance when it's published before the end of this year. And also, if you want any other information about the work of the National Data Guardian, there's the information for our website and Twitter.
Thank you. Thank you, Vicky. That was fantastic. And we have lots of questions. So I'm going to try and get these. This is a bit more difficult because I just want to look at the most recent ones after the second part. So actually, Chris, can you get to the first question that you wanted?
Yeah. So I'm just trying to order them in terms of ones that were there from before and ones that have come in. There's one particularly interesting one from Paul Hewitt, which is saying if we need the private sector in order to help drive the innovations we want, innovations that could drive benefits for patients, wouldn't it make sense to see the costs of managing data access a worthwhile investment of a relatively small amount of public money. Maybe we could put that to Wales and Scotland first.
So I mean, there is undoubtedly a role for the private sector and commercial companies in bringing innovations to the market and therefore make them available to the NHS, usually through a financial transaction. And there is no reason why enterprises such as we've been hearing from today shouldn't support that process. I do think that over the years there has been a misunderstanding about the potential total gross value of the data in the NHS to those such companies, and their willingness to pay what are sometimes estimated as astronomical sums of money to into their out of their businesses in order to get the advantages of the data that they aspire to. So I think maybe there's been some overestimation, some inflation of the potential value to the NHS and to the public purse through exchanges where pounds move around. So for me, the most immediate and the most obvious kind of pathways to benefit are not through those mechanisms. I'm not denying that they don't exist, but I do see a lot of commercial companies that are interested in accessing data, and somewhat speculatively, and very few of them really get to a point where I can see the impact that has occurred, by which I mean a public impact rather than a commercial impact for their companies. It's normally about ticking off some shareholder expectation, as far as I'm saying. So I'm a little skeptical about the real potential value, but I'm not denying its potential existence either.
Yeah, and from a Scottish point of view, I mean, I think I'd probably be on the same page broadly as David, that I've seen situations where academia, the NHS and industry come together and good things happen. The way that we set this up at the moment is that that it's only the academics or NHS staff that can directly access the data. But I think that there is a set of investment that we are putting in now. I mean, I guess that's part of Scottish Government's thinking, is that there's a lot of value in this for Scottish citizens through improvements to their health and care, and that's why they've invested in these data services.
Okay, shall I carry on doing down the questions for you, David? She's nodding.
Yeah.
There's one from Leslie Shannon that's been asked, which is particularly to Jeff. I'll read it out as it says, Jeff. Why would a company offer you more money not to share data, Jeff? And thank you for not working alongside such companies. I've read that two ways, so you can probably read that however you want to read it.
Well, I'll take the second half first. Yeah, absolutely. They shouldn't come anywhere near NHS data if they got that attitude. Why would they ask us to do that? Because there's commercial advantage in it for them. And what they particularly don't want is us to establish a data set, curate it, analyze it, tell a company, and they would quite like both the curated data and the analysis of that data as something they paid to generate to then be not available to other people. And absolutely, that's not something that Leeds is willing to do. So once the data is curated, that data becomes available for every local analysis, clinical, academic partnership, and other commercial product. And if companies aren't willing to work with us on those terms, then we won't work with them. And that's really easy. But there are companies who ask. And there are some relatively famous names that people may have heard of that Leeds just had to stop talking to because we couldn't agree on the definition of the word exclusive, which I have to say, I find a relatively straightforward word in the English language.
Okay, thanks, Jeff. That's a good answer. There are a couple of questions, Debbie, that are coming around data bill and the overall digital information bill, which says, I'll read half of the questions. One of the main aims of the Data Protection and Digital Information Bill is to facilitate commercial access to personal data. How will measures such as the abolition of data protection officers and allowing data controllers to decide what's anonymous increase public patient trust in use of those data? I'm not sure that's anything you've touched on, Vicky, perhaps, is it? with the NDG's office?
Yeah, I mean, I've only just sort of got my head around the new data bill. I mean, I think certainly one of the key drivers behind the changes is to make it easier to do research. And I think as the bill makes its way, it's only in the second reading at the moment in the House of Commons, makes its way through that process, there are things that we possibly do need to be aware of. Yes, obviously the replacement of data protection officers with the senior responsible officers. I think perhaps one of the things that's particularly concerning is some of the transparency requirements, whereby you don't have to provide information if the data wasn't collected from the data subject, is now being drawn across into Article 13. So it also applies where the data was collected from the data subject. So we would see that as diminishing transparency. And given what I said in my presentation and echoing many other people's presentations, that for us is one of the most significant concerns, anything that would diminish transparency around research. So certainly we will have our eye on that as it moves through.
And I think, Roger, you had your hand up first, and then David on that one.
Yeah, the only thing that I would say about this, I don't know whether David's going to make the same point, is that having a legal basis is one thing, but what you also need to operate in the data space is that social license, is the support of the majority of the public for what you're doing. And irrespective of what the legislation says, you know, we'd always be seeking to operate to you know, really strong processes, both on transparency and on other things. So I suspect lots of what's described in the bill, though I'm not an expert in it, that's the legal basis, but we're going to be operating to high standards.
Okay, there's a question from Pete Wheatstone, and it's for Vicky. It's about transparency. And does the National Data Guardian subscribe to the Use My Data definition of transparency?
It absolutely does, and it used the exact definition in its public benefit guidance following review by Use My Data. So we found that incredibly helpful, and that is how we are suggesting that transparency should be interpreted in the public benefit guidance.
Okay, thank you. I've got one question here as well from an anonymous attendee. And again, I'm not sure if this is directed, it seems to be directed at a number of participants. So I think it's a broad question. Is the role of the National Data Guardian under threat, or is it secure? Proposals for Information Commissioner's Office in the new digital bill don't build confidence. The government sees that public confidence and transparency are critical. Is Use My Data involved in any discussion on the new act? So if you would like to go first on that, Vicky, or someone else, does anyone else have? You go.
We do believe our position is secure. We have a very specific statutory role in terms of providing advice and guidance and assistance to the system in enabling them to safeguard a confidential health and social care system and use data where it's appropriate. We can't investigate, and we're not a regulator. So very much our role is about challenging, guiding organisations, but we believe ourselves to be quite influential, and many people do come to us for advice on their initiatives and projects. So, and we believe that our position is secure.
That's great. Jeff, you have your hand up there.
Yeah, I just wanted to comment. I desperately hope the role of the National Data Guardian is secure, because Leeds Teaching Hospital finds it fantastically useful that there is such an authority, and that a CAG, a confidentiality advisory group, can review a project. It's interesting that actually when the confidentiality advisory group grant an exemption, this section 251 exemption, yes, you can use this identifiable data, that there are good reasons that you need to do that. We actually would always follow that. But CAG would often provide a letter of no objection. You know, we don't see the concern here. And at times, to the immense frustration of Leeds research staff, the Trust would go further. The Trust would say, well, we don't mind that the National Data Guardian has no objection. We have an objection, and therefore we're not releasing data to this research project. And the classic thing that people will come to us is saying, oh, well, I've got ethics approval to do this project. Well, you know, ethics aren't the people releasing the data. The Trust are the data controller. We're the people responsible for releasing the data. And therefore an ethics approval to do this is not sufficient. So when CAG specifies what should happen, we'd always follow them. When CAG say this is not relevant to us, that doesn't mean the project can proceed if we disagree.
Okay. Chris, I'm going to ask you about, is Use My Data involved in any such discussions?
Oh, Vicky's got a hand up. Maybe she wants to jump in on that one.
I was just going to say, it's sort of echoing Jeff's concerns. I think historically CAG has been seen as, or the Confidentiality Advisory Group has been seen as an organisation that kind of sits in the way of access to data, but it absolutely is not that. It's the, you know, that is the body that protects the public's interest in use of data without consent. And I think, echoing what Jeff said, what we often find is that the multitude of different data access requirements at different organisations, you know, and people have spoken today about ones that I can see are very, very well developed, but actually some kind of mutual assurance and consistency across those access mechanisms, so that organisations can rely on each other's assessment, could actually be quite helpful here. And we hope that our public benefit guidance might help towards standardising some of that.
I think as a matter of principle, what Use My Data gets involved in is what's raised by the members of Use My Data.
Yeah.
There are two sorts of members. There's a full member, which would be classified as patients, relatives and carers, but we also have associate members as well. Anybody on this call might be an associate member. And I was just going to say, people who haven't registered, then they should do, because you can feed in your views, your ideas, your questions through Use My Data. And what we do is we corral those questions and we act as a secretariat on behalf of what the members are saying. So if they want us to get involved in particular projects, we do. And we're already working directly in lots of different areas of work with people like NHS England, with NHS Digital in particular, but with other groups as well around the country, some local, some national. But all our work is driven by what the members, the patients, relatives and carers think is the most important. Things like being able to access your care record, things like being able to view how your data has been used. So Phil's point about a data usage report always comes up again. So that's how we drive our priorities.
There's some more, there are more questions. I had a question actually about I suppose it's really with an increasingly big problem around energy use and a focus on sustainability. How are the various data banks taking into account the use of the data they have? And I thought Jeff touched on it as well when he was talking about data minimization. Is that something that we need to think about more cogently in the future? I know there's an energy crisis at the moment, but if we're not actually using stuff and we're just sitting on great stores of data, does that make sense to anybody? Is anybody?
Roger's got his hand up.
Yeah.
Certainly, I mean, I'm going to speak on somebody else's behalf here. So our colleagues at the University of Edinburgh are very conscious. They run data services for us and for many other organisations across the UK, and are acutely aware of their bills at the moment, but also the sustainability and what they have apart from just using energy that's bought sustainably, are looking at how they can heat local homes to their data centre based upon the heat that's generated from the data centre. So I think that whether that's common across the UK, but this is definitely something that is taken very, very seriously up here in Scotland.
David's got his hand up now, Debbie.
Okay, David.
Well, and I know Scottish colleagues are doing a lot in this space, but I do think it's an important point. I mean, it's perhaps slightly off topic from the point of view of this conversation, but it is relevant in the sense that the whole cost of running a data-intensive operation includes not only the electricity bills that you have to pay, but also the environmental consequences of consuming that electricity in the first place. So I think it becomes part of the equation, and we are, to some extent, kind of tracking where technology is taking us. So there's no doubt that technology, as if you buy the latest models of everything, is consuming less power and producing less heat as a consequence. And also conventional ways of storing large amounts of data is changing too. So certain types of data structures, I'm not going to get all technical on it, but actually are more kind of intensive on the machinery than others. And so I think all of us that are kind of investing in this, and we run tens of millions of pounds worth of compute, we're always trying to look for the next generation that will lower that kind of threshold, that will produce a lower environmental impact. I think it's just good practice, to be honest, and to try and make the best possible equation as cost and benefit. You want lowest cost, highest benefit.
I mean, I just wanted to briefly make the point that alongside the costs of storing data, it actually begs the question that relates to the security of the data of how many copies of a data item should the NHS hold. And actually, the hospital's got a copy. It's then sending it to NHS Digital to put in a TRE. We're talking is it actually safer to leave data at source in the hospital and then develop these federated analyses that, if you like, securely reach into the hospital, so they don't actually take identifiable data, they only pull out the analysis of the data. But actually the NHS Digital Cancer TRE, we have commented that it's a 65 billion row data set. What is the cost of the electricity bill to run that sort of thing? It's not nothing. And that has to be taken into consideration of what the right way to do it is.
Thank you for that. Joe, have you any thoughts that you would like to ask or comments on the?
Just for a question for Roger, actually, with the work that you're doing in Scotland, what needs to happen so that people are supportive of the work that you're doing, and that they are sort of safe in the assurance that their health data isn't being sold off short?
I think there's a number of answers to that question, Joe. So I think the first thing is about trying to get some messages out about what good has actually come from the use of data, and what we're trying to do is bring together people with some of that experience around Scotland, and connect to what's happening UK wide as well on that. I think the second part of that is about being really clear about who's using data, the sort of transparency of that. We're not, like I say, we're a really new organisation, so we've got a bit to go on that, but we've got plans to do that. And then I think the third thing has been really clear about the industry use of data, and I outlined a bit of that in my presentation, and we're not in the space where that's mature at all. So we recognise that we've got quite a long way to go, and to learn from people on this call and internationally as well, about what good looks like, and trying to emulate that. But we've got a set of, hopefully, a set of processes and principles that will guide us there.
Thank you.
But I'm conscious about the time, because we probably need to wrap up now anyway, because I think we're just about at time, Debbie.
Okay.
But I suppose the one point I was going to make was about the questions. We figured we wouldn't get through all the questions here. We've got logs of them all, and we'll be following them with either by ourselves or by comments that some of the presenters have already given us, or with the organisations who we need to put the questions to as well. So we're going to pick those up after this finishes.
Okay. Okay. So I think we'll probably, if we wind it up now, but I think this will continue in some shape or form, and I think we need to have a conversation about how that does go forward, how that goes, how that happens. I hope people have found out answers to some of the questions that they had. I hope I've certainly learned quite a lot this afternoon, and certainly about the complexity of the topic and how broad it is. And really, I think it's if you start at the top, it's about what we mean by big things like democracy and stuff like that. And I suppose really what we're trying to get at is the question can be framed as well about public benefit, about transparency and about fairness, and how we define those and who defines them, and how we make sure that we're going forward together in defining those. Whatever way you phrase it, I think we need more conversations like this, more deliberation.
And Debbie, just before we finish off as well, can we rerun the poll if Emma's not had her line dropped out?
Okay.
I know it was a fairly simple poll about do people think we sell data or not. Maybe we could get a response from people now to the poll that should be on your screens, just to see whether it's any different. The first poll at the start was almost exactly a third across the yes, no, and I don't know. And we got 100 and so respondents. Can you see those on screen? 76% of people are now saying yes, NHS data is sold. So I think if nothing, we've managed to draw some clarity about that simple word of selling, but we've also, I think, realized that it goes way beyond selling, and it goes way beyond just selling the NHS data, including into other services as well. So thank you for that, Em.
That's brilliant. Thank you.
I just want to say a couple of words to thank you, Debbie, first of all, for chairing this. Not an easy session for 3 hours. We've done very well. To all the participants, the panelists as well. I know it's a heavy chunk out of your days and your weeks, so we really do appreciate it. And particularly thanks to Emily, who's not on the screen here, who's done all the logistics around this and set the organisation up, and who will be chivying me and others to produce a summary of this to go on the website with a range of agreed actions on the back of this based on what we've heard and what the questions which remain unanswered. Sorry, Debbie, I just thought I need to say that.
No, that's it. I think we're pretty much there. I agree with you. Thanks to everybody, to all the presenters. Thanks for the questions. It's quite clear that you could talk about this, and there are so many points to talk about that it could have gone on for much longer. But I actually think in some ways this length is enough because it's quite intense, and we need to come at it again and do more of this more frequently. So thank you all. As ever from Use My Data, what we care about is public and patient involvement. And I think that's the whole way through the piece. It's in these sort of bigger discussions, in the nitty gritty bits, in the governance, in the oversight, everywhere. So we will come back to this, and you will be hearing from us in the next week or so, Chris, yeah?
Depends how fast I can type.
Brilliant.
But yeah, the recording will be up and the slides will be up when we get those signed off by the presenters. So people will be able to watch again with a cup of coffee and do it more calmly.
That's fab. Okay, listen, thank you all.
Thank you, everybody.
Bye.